This is Byron. He lives in Georgia with his wife and 2-year-old daughter. Byron was commissioned in the Marine Corps in 2011 as part of Operation Enduring Freedom. In 2014, he suffered a head and leg injury in an IED attack and experienced loss of consciousness and a subsequent seizure. He was medically discharged with a Purple Heart. With his immediate symptoms resolved, Byron returned home to his family and works as a substitute history teacher about 20 miles from his home. Because the school system does not offer comprehensive health care coverage to substitute teachers, Byron applies for VA health benefits. Byron is enrolled in VA healthcare and scheduled for an appointment with Dr. Biles, his primary care physician at the Atlanta VA Medical Center. Dr. Biles sees a recommendation in Byron's electronic health record to enroll Byron in VA's TBI care pathway and does so right away. 2 months later, while teaching, Byron loses consciousness, falls to the ground, and suffers a convulsive seizure. His students immediately call 911, and an ambulance transports Byron to the local hospital emergency department. Byron's seizure has resolved by the time he reaches the hospital, and he is treated for mild lacerations incurred during the fall. During his evaluation by the emergency care physician, Byron notes he has had a few episodes since the traumatic brain injury in 2014, but insists that they were short and he can manage through them. Byron is released from the hospital with a referral for a VA neurology appointment. Byron later sees Dr. Robertson, a neurologist from the Atlanta VA Medical Center, who inquires about Byron's seizures and periodic loss of consciousness. Byron explains that he's concerned he might lose his license if the Department of Driver Services finds out he's having seizures and he needs his license to get to work. Dr. Robertson conducts a neurological exam and orders an MRI, EEG, and complete metabolic panel to rule out other causes for seizure. Upon reviewing the test results, Dr. Robertson diagnoses Byron with epilepsy and prescribes valproate. He also asks Byron to track his seizures using a mobile app. Byron experiences multiple seizures over the following 4 weeks. Dr. Robertson's nurse is automatically notified and increases his valproate dose. Byron's seizures continue despite the increased dosing. Byron returns to see Dr. Robertson. Dr. Robertson prescribes levetiracetam, which may have a greater likelihood of success in treating Byron's epilepsy. With the help of this new medication, the seizures become well controlled. Byron is able to retain his license and is relieved he can continue driving and engaging in his work. 1 year later, after working in the yard, Byron experiences prolonged muscle spasm and goes to a non-VA urgent care center. He is prescribed baclofen, a muscle relaxant, but later receives an automatic notification that there may be an interaction with his levetiracetam, and an alternate prescription is provided. Byron safely recovers and is relieved to avoid another trip to urgent care. This is our vision for the future of healthcare for our veterans: seamless, real-time, analytics-driven, personalized care. The digital health platform enables this connected care approach to fundamentally transform the veteran experience.
Good morning. My name is Steve Rushing. I'm Senior Strategic Advisor for Health Information Technology at Georgia Tech. And yes, senior means old. I've been at this almost as long as Ed has and been involved with HL7 almost from its inception. So I've been anticipating a day like this for a very long time. I started with the video because that's where we started the project in Atlanta as a team of collaborators from the public and private sectors to build a digital health platform to serve our veterans for the next 40 years in terms of their healthcare provisioning. And if you're familiar with the VA, you know that they have been using Vista for the last 40 years as their workhorse, and it has done an admirable and fine job and continues to do it. But we wanted to look at ways in order to create a platform approach so that you can compose new experiences like you saw for Byron and 2 other personas we worked on. Nora, a female who needs women's services that are not available at her local VA, as well as Warren, a Vietnam-era vet who has all the comorbidities of getting old. On the screen, you can see the idea behind a digital platform. The one thing I need to always do is to say this is not a singular EHR replacement in terms of Vista. It is actually a platform approach that's put together through the API gateways that relies heavily on FHIR in order to accomplish what we needed to do in terms of liberating the data so that that seamless and frictionless care that you saw Byron receive actually happens, both at the facility in his community as well as any community-based hospital. I want to point out one thing that's very important, I think, to this group, is one of the paradigms we were looking to change is the acquisition of innovations by the VA. They get mandates from Congress that sometimes are not accomplishable in the timeframes that Congress would like for it to be done, and they need to rely on communities like this room in order to fulfill this part on the right-hand side. So one of the things we did is looked at a way to create demand for your innovations, and we're hoping that as you collaborate with one another going forward on FHIR, you provide the innovation supply. The other thing we proved is that you could do this, and I'll pick up where the last presenter, by doing it in public-private collaboration, using agile approaches, doing domain type design, we were able to accomplish building the platform around which you saw Byron's care done in just 3 short weeks, working weeks. And by the way, there was no smoke and mirrors in there, and there's no hand puppets. All of those APIs, in fact, work, and we demonstrated it live to the Secretary of the VA in October. I want to wrap up my part here quickly. I just want to point out that the way that the platform is set up is that every component knows what the other components are doing, and it's guided by the intelligence and the analytics layer in cooperation with the API layer that keeps everything harmonized and coordinated across the components. And now I'm going to let my colleague, Niall Darby from MuleSoft, explain how the API gateway was architected, because this is a very important piece. The gateway is not a loose bunch of interfaces that we collected. It was intentionally architected in a specific way.
Thank you, Steve. Okay, so we go back to an overarching theme to the goal or the vision of the digital health platform, which is a better experience for the veteran. You know, we consider what is a better digital experience and what has FHIR got to do with that experience. I think we could simplify it in terms of a common and unified exchange of information that's always complete, it's always accurate, and it's on time, and it's contextual, you know, unified across every interaction with every provider or directly through any particular digital channel, whether it be mobile or web or whatever. So that the patient, the veteran as a patient of this healthcare delivery mechanism is treated like a customer would be treated in a retail context. You know, there's that common experience that you don't get a better deal in any particular channel of interaction. It's always the same high quality interaction, regardless of how they engage with the clinicians. So the platform, looking at FHIR and looking at that need for that commonality of experience, you know, Gateway is part of it, of course. It's about how we facilitate the likes of innovations that you've seen this morning, establishing the platform, if you like, as a platform for innovations. And so we look at Gateway and we think, well, in the clinical context, the ideal language of choice to facilitate the interoperability that would be absolutely necessary for the innovations that you're seeing this morning is, of course, FHIR. And so that becomes, in the clinical context, the language that we chose when we designed our APIs. But there is something more, of course, than what's immediately visible at the gateway level, and that's the reality that we have to integrate with a number of back-end systems of record, not just the EHR, also CRM systems treating the patient like a customer relationship, financial systems, analytical systems, of course. You know, so all of that is present, and there's obviously a need for integration. There's a natural correlation between APIs and integration, so Obviously, every implementation of every API necessarily involves some sort of an integration solution. So MuleSoft, with our platform, we had to co-architect this with Georgia Tech, this solution, and of course the APIs that we built and designed and developed are hosted on our platform. If you think about this need for a better experience and how we would achieve that, well, one way to do it is by breaking down the coupling that always exists between a particular channel of engagement and any particular back-end systems of record. So MuleSoft recommends this approach of API-led connectivity, whereby you address the needs for integration and APIs by looking at what are the core capabilities that we want to digitize. Now, as a rule of thumb, that just becomes the bare bones business entities or information sets that are needed to be exposed. And of course, FHIR helps there too, so FHIR doesn't just necessarily sit at the gateway level for us. We actually exploited it down at this bottom layer where we're identifying those business entities, the likes of observation or medication or patient or condition. These become core digital assets that will necessarily have an impact in a number of different contexts. And one of the prime contexts for impact, of course, is the clinical workflow. So you can imagine each clinical workflow will necessarily want to reuse the likes of a patient API. So all of those are digitized separately, but we've also got to consider the workflow themselves as separate APIs, separate core building blocks, if you like, so that we do build up this platform for innovation. At the top layer then, we have this question of experience APIs, where we're adapting these core assets for every engagement across every channel, across every innovation that you've seen highlighted this morning. So the question of adapting existing APIs is just a fraction of the effort of what it costs to design and build the core assets of the system and workflow APIs. Okay, so I'll hand you back now to Steve to take a deep dive on one of those areas.
Well,
Oh, actually, sorry, I'll cover that, yeah. So yeah, the approach that we took when we were looking at the use cases that we had to digitize, of course, the first prime candidate is, well, what is the clinical workflow? An encounter, for example, or a referral or whatever. And then what are the core sets of information needed as we interact with the patient in that particular workflow? And then, of course, we end up talking about patient or condition. And we exploit the definitions that FHIR has already made to express what that API capability is. That's what we did on the first pass for the first scenarios. And then as we pass into other scenarios, then we were able to exploit and reuse and adapt the previous efforts.
And we'll skip the diagram. We can talk behind this just a little bit. We went into the second sprint. This happened to be Nora. We did the digital mobile app in order to help her in her care with the community level. In our community hospital for this, by the way, was Duke University, and the work that Ed and Steve Woody did to help us connect our sandboxes together to prove that we could actually do this at the community level. And this is a priority if you know the VA, because they have to get the choice program up and running here in short order. So I'll wrap up and say that we were about changing the experiences of the veteran and the clinicians who were serving them, and that the platform is designed to go into areas of innovation, like we've been saying, that's represented here in the room, but more importantly, to create a platform in which innovations can come that we might not even know is possible today, but we were able in the proof of concept to say, this is the map that would lay out a way for the VA to transform itself over the next 40 years. Thank you.